So for our third speaker, I would like to invite Thomas. Thomas, the floor is yours.
So very good morning, everybody. Thank you so much for the invitation. Thank you, Mark, for being nice and and inviting me here. I also have a presentation to share with you, if you don't mind. I hope you guys are looking at my presentation. So the idea today is to speak about something that I've been working for some years now, which is public-private partnerships in health, especially related to a program that we are developing here jointly with BNDES. I'm part of the IFC, a World Bank arm, but we have a partnership with BNDES, the local development bank, and IDB. It's a program to foster PPPs in Brazilian municipalities by means of primary healthcare. The question that was posed to me was why and how partnerships between sectors and private and public sectors can really show positive outcomes to solve the NCD issues and lessons to be replicated. So that's why I decided to speak here about partnerships, which is the core of my work. So this is a little bit of the outline that I prepared for this presentation. I hope that I have time for the very first part would be to speak very loudly about the healthcare challenges that we see and why IFC and this group is involved into the making of PPPs and trying to bring the private sector into healthcare issues. Then I'm going to try to put everybody to the same page of what a health PPP is and what it means for the countries. Then I'm going to go specific into a study that we've been conducting jointly with BNDES for fostering primary healthcare PPPs and the business model that we prepared and we want to escalate in Brazilian municipalities. And then I'll speak a little bit about some of the market perceptions that we were able to collect throughout this study, and then show you where we are in terms of this pilot program. So I really like this very first this slide because it shows the ideas of why IFC and why this group is involved in health, why health is important for us. First, there's the growth angle. Of course, 1 extra year of life generates more GDP. There's a study that shows that 1 extra year of life can generate an increase of about 4% in GDP. There's the social development angle. For instance, in China, 0.1% decline in the maternal mortality rate, showed to have a correlation with the reduction of female illiteracy. There's, also the productivity angle. The same study showed that when you have better health, you can improve. You can have more than 33 million productive life years, which are now drained due to cardiovascular diseases. We can, generate more jobs. 40 million new jobs expected to be crafted until 2030 by means of healthcare. There's also a very important effect in terms of demographics. When you have a better healthcare, you don't have the burden of elder care being only on women. So you see the relationship and the correlation between that and the reduction in women's work hours by around 40%. And lastly, when you have very important healthcare investments, this is also associated with a higher level of foreign direct investment. So this is all the angles that we see and why we think it's very important to be involved in the healthcare sector. Again, speaking a little bit about our mission, why we think that we need to foster private sector, the private sector role in healthcare. I think that there are 3 basic buckets that we have to think here. First is to really increase the access to basic health services, which is currently very limited. So we do think that the private sector has a good role to play in terms of providing higher access to affordable quality healthcare. Second, if we look at the numbers, there's an enormous gap in terms of investment needs. There's this UNTAD study as of 2019 that shows that there's investment need of $200 billion to really be able to meet the SDG 3. As of today, we have investment levels of around $70 billion. So there's a huge gap to be taken, and we think that the private sector has has a good role to play here of around 40% of the total annual investment needed that can come from the private sector. And thirdly, of course, the governments worldwide, it's not only Brazil, but worldwide, it really has a very tight fiscal space. We have a macroeconomic condition which leads to rising debt burdens. So, and at the same time, we have governments competing for resources and having competing priorities. So again, it's very important for the private sector to come in and to provide private financing for meeting these goals. Especially regarding non-communicable diseases, we have the statistics that show that NCDs account for almost 70% of deaths in low-income countries and middle-income countries. At the same time, these diseases are only receiving 1% of the development assistance. So it's unproportional to the number of deaths that NCDs cause. So again, just to make the point, the private sector has a lot of roles to play here to meet the gap, either in terms of financing and also in terms of expertise. Just to finalize here, the roadmap to SDG 3. So SDG 3, as you may know, is to ensure healthy lives and promote well-being. So again, showing the study of Untitled, showing that there's a need of $210 billion up to 2030, and there's additional possible private investment of 70 billion to really meet this gap up to 2030. And how we can come up with these numbers. First, we do have to enable the environment for private sector. We have to, I'm speaking very loudly, but we have to strengthen the regulatory regimes. We have to improve planning, and we have to set standards to facilitate private sector investments. We have, of course, to widen insurance coverage to promote more affordability in countries, especially for low income and rural populations. In terms of private sector engagement, we have to enable tools for private sector participation, such as Ppps, such as outsourcing or specific services such as medical waste, pathology, et cetera. And the fourth part of this roadmap is to really create the market, create the opportunities, lead initiatives and investments that can really foster innovation and foster competition, can have demonstration effect to the private sector, and then can be replicated in countries all over the world. So now speaking very, very shortly about what a PPP is, and not speaking necessarily only about healthcare PPP. I'm speaking about infrastructure, core, and I would say social infrastructure, as we call in the literature. What are the objectives and advantages of PPPs? First, we have a wider access of sources of financing, not only public financing, but also private financing. And there are many ways, many tools to have this financing be attracted to these opportunities or to these operations. We can, by means of PPPs, we can have access to better industry practices. We can improve the quality and services standards by means of an output-based contracts, and not really necessarily input-based contracts, by means of KPIs, by means of incentives-based contracts with governments. We can, of course, we try to really put governments into the focus of designing policy, designing planning and regulation, not really operating the equipment, and not really operating the healthcare facilities. We can also, of course, generate more predictable and long-term budget commitments. And lastly, I think that one thing is very important over the long run is to generate value for money. When you do contracts, when you do agreements that can generate a competitive bidding process and can adequate risks between private and the public sectors in a very adequate manner in the long run, by means of well-structured PPP agreements. So this is also very important. In terms of healthcare designs, this is the spectrum of healthcare PPP models that we can see in the world. This can come from more simplistic types of PPP, such as management contracts, where you still have lots of public sector responsibility, not too much of private sector responsibility. And then you can go up to a higher degree of complexity, such as integrated PPPs, where you have the whole set of scopes in a healthcare PPP being transferred out to a private sector, where you have a higher degree of complexity and a higher level of private sector responsibility. But in between, you have a long array of possibilities of transferring these responsibilities. Just to be now coming to the bulk of my presentation here, this is the study that we've been conducting with BNDES in this PSP infra for over 1 year now, which is, we started off by being kind of ignited by the Brazilian Investments Partnership, which is a federal government entity, on why there's not so much PPPs in the Brazilian public primary healthcare located to pertaining to the SUS, to the Brazilian healthcare system. And indeed, when you look at the statistics, there are not very many not very many cases in the public healthcare domain. So we prepared as you know, in these institutions, an improved methodological framework to really understand how to better engage private sector in the segment, especially in the primary healthcare segment. We do have, as institutions, we do have a good understanding of financing of healthcare providers, but not really in the design of PPP. So we really wanted to stimulate that market to happen, especially in Brazil. But having said so, we participated in some of the very first healthcare PPPs in the country in the past. So we designed the very first emergency hospital PPP in the country, in the state of Salvador, back in 2012. It's almost 300 emergency hospitals PPP. It's an open doors hospital PPP linked to the SUS, to the Brazilian healthcare system. Was won by a consortium, and is currently operated by a French-Brazilian consortia company, and it's basic. Here's an integrated PPP. It's clinical and non-clinical services being implemented and being operated by this consortium. We also have been engaged in imaging diagnostics PPP, the very first in the country, also with the state of Bahia, taking into account the telemedicine and teleradiology systems that you know, technology provides for. It's a consortia that is composed by Alier, a medical provider here in Brazil, Philips, which is a vendor, and Fiji, also another Brazilian company. The idea here is to provide reports, radiology reports, to 12 hospitals spread out over the state of Bahia, with radiologists being centered in the capital city in Salvador, and really providing the reports, providing the tests to these 12 hospital wards over Brazil. And then the only primary healthcare PPP, which is located in the city of Belo Horizonte. It's also a project was designed by us. It's a PPP, a healthcare PPP, PFI as we call it. So it's not really integrated services PPP. It's only for non-core services for 77 new healthcare units spread out in that municipality. So just to show some of the experience that we have already. So it's not really something new. It's already happening. What we want is to replicate. So this is another stories that we have developed in the world. So we have experiences in Turkey for 30 plus health campuses. In Turkey, we have also designed the new Bossa Hospital as a PPP in Colombia. It's the very first in Colombia. 25 pathology, 25 radiology centers in India, and the one that I just explained, the Bahia Imaging Diagnostics in Brazil. So we have experiences not only in Brazil, in other places already functioning. So now coming to the study, this is the study that we developed jointly with BNDES to really assess the gaps and issues faced by the improved provision of services in primary healthcare services in Brazil, to really, you know, be able to attract more private sector participation in primary healthcare. So the idea was to propose a PPP model that could be feasible for municipalities and at the same time scalable for a wider range of municipalities in Brazil. We came to some conclusions. First, the first outcome in primary healthcare is that child mortality rate, as you may know, we have as of 2019, 14 mortality rate of 14 over 1,000 babies born alive. So this puts Brazil into the 81st global rank position. So I mean, there was a lot of progression over the years, but we are still far from reaching our goals. In terms of coverage in primary healthcare, we want to achieve universalization. So we're currently around 65%. So there's still, again, there was lots of progress being done in the past, but we're still far from 100%. At the same time, there's a census that shows that There's lots of infrastructure needs in basic healthcare units. 50% of the whole network of basic healthcare units in Brazil requires some type of retrofitting or some type of reform. And at the same time, when we look at the clinical ratio, the clinical production is still low. Efficiency is still low as compared to other countries in terms of consultations, in terms of procedures. Of course, we have a good ratio in terms of doctors per 1,000 inhabitants, but we are still far from nurses over 1,000 inhabitants if we compare with other countries. And also we have an access issue with to provide better diagnostics. Lots of unmet demand for basic diagnostics, which has a lot to do with the lack of internet band and internet technology in 50. We don't have internet band in 50% of the municipalities in Brazil. So still far from the basics, right? So this makes us spending around 40% of GDP, which is still a low level as compared to OECD countries or middle income countries, according to a survey by IBGE. So we started looking at the experiences. Again, I don't want to go too much into detail because I don't have time, but we have infra experiences, we have primary care PPPs. And I think that the most important experience and kind of role model here would be the so-called NHS lift, which is in the UK. We have services PPP. We look at experience in Rwanda. We also looked at walk-in centers in NHS. And I think that the most known experience of an integrated PPP, although we have ours in Brazil, is the Alzira PPP in Spain, which has the whole spectrum of PPPs, and a capitation model was transferred out to a private sector. I'm going to go again now to the model. So this is the model that we are proposing in this study. First is to have, we have a high, an angle here for new construction of basic care basic care units in Brazil or retrofitting. The idea is to also have a municipal diagnostic center to be implemented by these municipalities, and also take into account the new regulations in Brazil regarding telemedicine and teleradiology, is to have a municipal telemedicine platform in these municipalities, and this can be modulated and can be escalated to the wider array of municipalities that we have in Brazil. This is a little bit of the scope. Basically, private will again, be basically related to civil works, to the management of this municipal diagnostic center, to I would say facility management services provision, and the public would remain with HR management and with the management of this clinical services over the long run. So as part of the study, we went to the market to really try to get a sense and to get a feedback of what these ideas meant for the market. So the conclusions are that first, the market is there. Obviously, we have to look at the modeling features, but the market is there. There's an appetite for this type of business case. In Brazil, we still have ideological position, but it's much better than we had in the past. And I think that communications is very important to make these ideas come through. Scale and efficiency are really key. The high number of covered units and test exams are really important for the private sector to make it viable. Of course, HR management is very key. So we still have to think on how to really involve HR into the private sector responsibility. I don't have to say that the use of technology and data integration is even, is each day more important, and is very, very key to have an improvement in the regulatory framework, especially regarding public guarantees, since we're speaking about long-term contracts with the private sector. So public guarantee scheme, public guarantees is key, and payment systems is also very important in this equation. So this is the program that we are doing now with 5 Brazilian municipalities. We have already 2 signed, 1 being signed very, very soon. So we have 3 already in the pipeline. We are, IFC and BNS is coordinating this effort. It's a pilot program. We have technical consultants already hired, and this is going to take 14 months until the project goes to the market. So that's it. Thank you very much.